Good morning. So today my topic is the drugs which are acting on the renin-angiotensin-aldosterone system. Is a part 2. I have already discussed about the captopril and other angiotensin converting enzyme inhibitors in the part 1. So today we are going to discuss about the angiotensin receptor blockers, that is the orally active AT1 receptor blocker, which can be used as an alternative to angiotensin converting enzyme inhibitors. The drugs that's included in this group are losartan, valsartan, irbesartan, candesartan, iprosartan, telmisartan and other, all the sartans are coming under this group. So for the next slide, we are coming how it acts. So what is the mechanism of action? As I have already told you about how the angiotensinogen is converted to angiotensin 2 and it has the actions on the blood vessels doing the vasoconstriction. So angiotensin 2 antagonist or ARBs, it have this kind of mechanism of action that angiotensinogen is converted to angiotensin 1 with the help of renin. It is again converted to angiotensin 2 with the help of angiotensin converting enzyme. This angiotensin 2 has an effect as a vasoconstriction and also that is the aldosterone secretion. What is happening? There will be the sodium and water retention and ultimately there will be increase in the blood pressure. So here comes, we know that ARBs, that is the angiotensin receptor blockers. These blockers having the effect on the angiotensin receptors, specifically the AT2 receptors, and that is the selective antagonist for the angiotensin 2. So this is the mechanism of action of the ARBs or angiotensin receptor blockers or angiotensin 2 antagonist. This picture I have already shown you how this humoral effect, that is how the blood pressure has been maintained by the RAAS system. So we can see here, this is the preload given by the inferior vena cava and this is the afterload which is produced by the aorta. Now this is a sympathetic ganglion. Now when there is a sympathetic stimulation, there is a beta 1 stimulation on the kidney and there will be the renin release, and that is also equal to the volume depletion. That is, there is sensation, there is a volume load is less, like sodium ion load is less, so there will be the release of the renin which is converted to angiotensin 1, then angiotensin 2, then production of the aldosterone. Ultimately there is a retention of the sodium and water and increase in the blood pressure. Now what is happening? We can say this is the ARB, that is, it is blocking the activity of the angiotensin 2, so it is acting on the receptor AT2 and again it has the effect on this heart and also effect on this, you can see on this receptor, that is the angiotensin 2 blocking is the activity. So these are the mechanism of action of the ARBs or angiotensin receptor blocker. Now we are coming with a prototype of drug, that is the losartan. So angiotensin receptor blockers, the prototype of the drug is the losartan. It is a competitive antagonist as well as the inverse agonist for the receptors which are the type 1 receptor AT1, more selective for the angiotensin 2 type 1 receptor, that is the AT1 receptors, than from the AT2 receptor. So it does not block the other receptors or the ion channels except the thromboxane A2 receptor. You know the thromboxane is responsible for what? It is a pro-aggregatory. So it will increase the platelet aggregation. So it is effective in the bleeding diathesis. Now the physiological functions of the angiotensin 2 is mediated by the AT1 receptors. So what are the physiological functions of the angiotensin 2? Those are the vasoconstriction, central and peripheral sympathetic stimulation, catecholamine release, aldosterone synthesis, renal sodium and water retention, and what is happening when the blockers are given, all these functions are blocked. Other central actions like the thirst, the vasopressin release, and the growth promoting actions on the heart and the blood vessels, those are also blocked by the ARBs. There is no inhibition of the angiotensin converting enzyme has been noted. So blockade of AT1 receptors increases the plasma levels of angiotensin 1, angiotensin 2, and also aldosterone. And losartan causes a fall of blood pressure in the hypertensive patients, which lasts for 24 hours, and heart rate remains unchanged. It is very important that there is no alteration of the cardiovascular reflexes. ARB differs in some aspect from the ACE inhibitors. Number one, it does not interfere with the degradation of the bradykinin and other ACE substrates. So what will happen? There is no degradation, although not interfere with the degradation of the bradykinin means there will be no cough, and alteration of the taste is also very rare. Number two, response to angiotensin 2 generated via the alternative route and consequent activation of the AT1 receptors are also blocked. There is an indirect activation of the AT2 receptor that results in the vasodilatation, and ARB also causes the little increase in the level of the angiotensin 1 to 7, which is increased by the ACE inhibitors as angiotensin 1 to 7 is degraded by the ACE. So what are the difference? Main difference that it is not interfering with the degradation of the bradykinin. So there is no cough and there is no alteration of the taste. So bradykinin is getting degraded, getting metabolized, there is no increase of the bradykinin in the plasma, and ultimately there will be no dry cough. And also we can say angiotensin 2 which are generated by any alternate pathway, it will not have its effect on the AT1 receptors and will not increase the blood pressure. It is also that there is an indirect activation of the AT2 receptor which is ultimately resulting into the vasodilatation. And ARBs causes little increase in the level of angiotensin 1 to 7, which is increased by ACE inhibitors, as angiotensin 1 to 7 is degraded by ACE converting enzymes. When we are giving the inhibitors, it is increased, but for the ARB, it will not increase, and only a little bit increase may occur. Now, what are the pharmacokinetics for the ARBs? Oral absorption of the losartan is not affected by the food. Bioavailability is only 33% due to the fast plus metabolism. Number 3, it is partly metabolized in the liver to an active metabolite, which is more potent and non-competitive AT1 receptor antagonist. Peak plasma level is attained in 1 hour and 98% plasma protein bound, and it is excreted by kidney. What are the side effects of these sartans? All the sartans are the angiotensin receptor blockers. Now what are the side effects? There will be the dizziness, angioneurotic edema has been reported, but it is very rare. There may be hyperkalemia, which is comparable with that seen in the patient which are being treated with the ACE inhibitors. There may be the risk of fetal injury and the death. That's why this drug is not used in the second and third trimester of the pregnancy. There is a symptomatic hypotension in the hypervolemic patient. There is the absence of the cough and the alteration of the taste. Fast dose hypotension is rare. What are the uses? Most important use in the hypertension. It is a first line of drug, and maximum effect is reached within 2 to 4 weeks. Ventricular and vascular remodeling is arrested. Congestive heart failure is another indication for the symptomatic relief. Myocardial infarction, it can be used. Diabetic nephropathy, it is renoprotective, especially in the patient who are suffering from type 2 diabetes mellitus. Now, there is an option for the combination of the ACE inhibitors with the ARBs, because there is some function which are helpful for the ARBs and ACE inhibitors. So ACE inhibitors is combined with an ARB to obtain more complete suppression of the renin, angiotensin, aldosterone system. So it is more cardioprotection in case of the congestive heart failure and more renoprotection in case of the diabetic nephropathy. So this combination is very much welcome drug for this treatment of the patient with the diabetes mellitus suffering from the renal disease. Aliskiren. So it is a direct renin inhibitor. It is the latest class of the renin, angiotensin, aldosterone system of the drugs. It is a nonapeptide and binds selectively to the catalytic site of the renin. It competitively blocks the access of angiotensinogen to the angiotensin, that is, it is the angiotensin 1 is not produced. Angiotensinogen is the substrate from which angiotensin 1 is produced with the help of renin. When the blocker has been given or the renin inhibitor is given as an aliskiren, there is no production of the angiotensin 1. So it causes a fall in the blood pressure, especially in the sodium depleted patient. Plasma aldosterone level is also lowered with the natriuresis and potassium depletion. Postural hypertension usually not seen, and reduce the hypertensive left ventricular hypertrophy and benefited the congestive heart failure patient. It is recommended as an alternative drug, as an antihypertensive drug for those who are not responding to the first line of the drug. What is the pharmacokinetic? It is orally given. Bioavailability is very low due to the active excretion of the drug with the P-glycoprotein. Bioavailability is very low. You have to remember this because the active drug get excreted from the body with the help of P-glycoprotein. It is also eliminated in the feces. What are the adverse effects? Adverse effects are dyspepsia, abdominal pain, loose motions, headache and dizziness. It is contraindicated in pregnancy. Now you are coming to the last part of this topic, there is the plasma kinins. You know these are the bradykinin and the kallikrein. The kininogen is the substrate on which the kallikreins are acting, producing the bradykinin. As you know, if the bradykinin is present, you know there is no degradation with the help of ARB, but degradation when ACE inhibitors are given. So what is happening? It acts indirectly. Contain enzymes which generated the active substances in the plasma. Kinase generated by the proteolytic reactions is triggered by the tissue injury, inflammation, allergic reactions, all those. Now what are the actions on the cardiovascular system? Bradykinin is a potent vasodilator. So dilatation is mediated through the production of the nitric oxide which is produced endothelially and prostacyclin generation and involves mainly the arterioles. It also releases the histamine and other mediators from the mast cells. Injected kinin causes the flushing, that is the flushing of the feces and other parts of the body. There may be the throbbing headache because the main function of this is a vasodilatation and there is a fall in the blood pressure. Intradermal injection will produce the will and the flare as like the inflammation. Smooth muscles, it causes a marked bronchoconstriction as in the asthmatic patients. Neurons, it is strongly stimulate the nerve endings that transmit the pain and there is a sensation of burning sensation. Now kidney, kinin produces the renal blood flow as well as facilitates the salt and water excretion by acting on the tubules. That means it is what it is happening, there is a salt and water excretion with the action on the tubules and there is an increase in the renal blood flow. Kinin receptors are the two types of receptors, the beta 1 receptors and beta 2 receptors, and these bradykinin is selective agonist for the beta 2 receptors which is a G protein coupled receptors. Now beta 2 receptors which are present on the visceral smooth muscles, there is a contraction of the intestine and the uterus and the airways, so it is causing the bronchoconstriction in the asthmatic patients, and it is also present on the vascular endothelium. So nitric oxide mediated, there is a vasodilatation and increase the permeability of the arterioles. Sensory nerves, it causes acute pain sensation or the burning sensation. Bronchoconstriction and the renal vasodilatation, it can be attenuated with the help of aspirin. Okay, when it is given pre-treatment with the aspirin, this bronchoconstriction, which are the side effects, you can tell it, and also the renal vasodilatation, that can be overcome with the help of aspirin. Okay, next, what is the pathophysiological role? Number one is a mediation of the inflammation. That kinin is a very important mediator of the inflammation. It causes the flare, it causes the will. It also involves in the allergic reactions. There will be the increase in the blood flow. So you know all these are in the symptoms of the allergic inflammation. That is, there may be angioneurotic edema, maybe rhinitis, maybe asthma. Also it helps in the mediation of the pain. It stimulates the nerve endings by increasing the prostaglandin production, and there is a pain, burning sensation. Production of the kinin integrated with the clotting, fibrinolysis and complement system. It is involved in the shock, rhinitis, asthma, ACE inhibitor, induced cough, all this. What is the bradykinin antagonist? It is a very new drug. So it is known as a icatibant. It is a very new drug and it is a selective beta 2 antagonist, resistant for the kinin degrading enzymes and having the longer half-life. Now this still now approved, it still not has been treatment is not given and it is approved in the Europe, but symptomatic treatment for hereditary angioneurotic edema, it has been approved in Europe. So we can tell in a nutshell what will be the Now, for the summary, what we can tell? First of all, you know this renin-angiotensin-aldosterone system is very important. This RAAS, that is called the renin-angiotensin-aldosterone system, the RAAS system. It is important, very important for the maintenance or for the blood pressure. Okay. Now, the drugs which are acting on this RAAS system, how it is acting? Number one, we can tell which is directly involved in the renin. That is, the renin production has been decreased. By whom? By the beta 1 antagonist. Okay. So clonidine also very important in this factor. Centrally acting sympatholytics are also important for this. So it is what is happening, the renin secretion has been decreased with the help of this beta 1 selective antagonist. Number 2, we are coming to the ACE inhibitors. ACE inhibitors. As I have told you, ACE inhibitors, very important prototype of drug is the captopril. You know ACE inhibitors, what it is happening? It is preventing the conversion of the angiotensin 1 to angiotensin 2, and this angiotensin 2 is having the effect on the AT1 receptors and causing what? It is causing the vasoconstriction. So when the blocker has been given or ACE inhibitors has been given, there is no effect of this vasoconstriction, instead there will be the vasodilatation. Now what will happen? The important drug, as I told you, the prototype of drug is the captopril. Next, captopril is orally active drug, and the next drug is the enalapril. Enalapril, okay. This enalapril is a pro-drug. So captopril, as I told you, it is an active drug, okay. It's an active drug. We can give it by the with food or orally we can give it. Enalapril, it is a pro-drug. So it have to be converted in the enalaprilat. Enalaprilat, okay. So what will happen? This enalaprilat is an active drug. Next is coming the lisinopril. The lisinopril is again a prodrug. It's a lysine derivative. Lysine derivative of what? Enalaprillate. Okay. Now, most of these drugs is being excreted with the help of the kidney. Okay. Only one drug we can tell it, that is going to be excreted with the help of the liver. So, what is important for us? When there is a derangement in the liver function, it may not require for the alteration of the dose of these drugs, but when the kidney impairment is there, you have to alter the dose of these SA inhibitors. Now, after that, what is coming? After that is coming the third group of drug, that is the angiotensin receptor blockers, which is nowadays very important. All the sartans are very important in this aspect. So, nowadays telmisartan, olmesartan, different kinds of drugs are there. The most important is that what is the difference with the sartans with the SA inhibitors. As we know already, I already discussed about it, that's SA inhibitors, what is happening? It is not blocking the angiotensin 1 receptor. What is happening? It is only blocking the production of the angiotensin 2 from angiotensin 1. So, if there are the other pathways for the production of the angiotensin 2, then it will have the effect on the angiotensin 2 receptor or angiotensin 1 receptor, and it will produce the vasoconstriction, ultimately leading to increase in blood pressure. In case of ARB, it is what is doing? ARB is completely blocking this AT1 receptors. Okay. So, there will be no increase in the blood pressure. This is the number 1. Number 2 is that most important, there is no degradation of the bradykinin. Okay. In case of the ARB, there is no increase in bradykinin level, and ultimately what will happen? There is no cough and no alteration of the taste. These two are very important difference between the ARB and SA inhibitors. Okay. Now, what we can tell about this, that's in a nutshell, most important drugs are the SA inhibitors, especially for the diabetic patient, the patient suffering from diabetic nephropathy. Those are very important, and also important for the cardiac remodeling. So, it is also important what? Important for the congestive heart failure patient, CHF patient suffering from the hypertension, and also for the myocardial infarction patient. And when we are combining these SAA inhibitors along with ARBs, nowadays this group of drugs are very popular. When we combine this, there is a total effect of the decrease in the blood pressure. There is no increase in the blood pressure ultimately will occur, because if any angiotensin enzyme will be there will be no action on the AT1 receptors. And what will happen ultimately? There will be no detention because aldosterone production has not been there. So, there will be no detention of sodium ion and also the water, ultimately leading to there is a decrease in the blood pressure. Because as there is no detention of the sodium and water, there is no increase in the volume pressure and there is no increase in the blood pressure. So, ultimately blood pressure will be decreased. So, as there is no aldosterone secretion or increased production of the aldosterone. So, these are very important. One drug is there, that is a spironolactone. We know it is an potassium sparing diuretics. Okay. And this drug is the aldosterone antagonist. But you have to remember this, we will discuss about this drug in diuretics, not here. Just remember, aldosterone antagonist is the spironolactone, which is a potassium sparing diuretics. And potassium increase happens both made with this SO inhibitors and ARBs, so we have to be careful about it, about the electrolytemia. So, for the important questions about this chapter, first, how the blood pressure has been regulated with the help of this renin, angiotensin, aldosterone system. That is the number one. Number two, you should write a short note on captopril. Okay? And what is the difference with the enalapril? You have to remember about it, which are the pro-drugs. Again, you have to know about the sartans. All the sartans are very important nowadays, and what is the difference between the sartans and the captopril? This is important. And ultimately, lastly, aliskiren, that is the direct renin inhibitor. Okay? Direct renin inhibitor means there is no increase in the angiotensin 2, so it is also very important. So, about all these drugs you have to know and you have to understand about it. I think you can come to know already part 1 has been discussed, as already discussed. So, thank you everybody. Thanks for your attention.